Question 1. During the evaluation of a 55-year-old patient presenting with chronic low back pain, who reports significant functional limitations and emotional distress, which of the following assessment strategies would best reflect current best practice in pain medicine within the Australian context? Option A. Relying solely on the patient's self-reported pain intensity score to guide the diagnosis and treatment plan, without further objective assessment or exploration of functional or emotional factors. Option B. Administering a validated pain intensity scale and a functional disability questionnaire, followed by a targeted physical examination and a discussion of the patient's perceived impact of pain on their daily activities and emotional well-being. Option C. Focusing exclusively on a detailed neurological examination to identify a specific nerve root compression, disregarding the patient's subjective reports of widespread pain and emotional distress. Option D. Immediately initiating a trial of opioid analgesia based on the patient's report of severe pain, without a comprehensive assessment of the pain's etiology or its impact on function and mood. Correct answer is B. Administering a validated pain intensity scale and a functional disability questionnaire, followed by a targeted physical examination and a discussion of the patient's perceived impact of pain on their daily activities and emotional well-being. Explanation. This scenario presents a common challenge in pain medicine. Assessing a patient with a complex history and multiple potential contributing factors to their pain, where subjective reporting is paramount. The professional challenge lies in differentiating between nociceptive, neuropathic, and psychosocial components of pain, and in accurately gauging the impact of pain on the patient's function and quality of life, all within the ethical and legal framework governing pain management in Australia. The correct approach represents best professional practice by employing a comprehensive, multimodal assessment strategy. This aligns with the principles of evidence-based medicine and the ethical obligations of pain specialists to conduct a thorough and unbiased evaluation. Specifically, it adheres to guidelines that emphasize understanding the biopsychosocial model of pain, which is fundamental to effective pain management. This approach ensures that all relevant aspects of the patient's experience are considered, leading to a more accurate diagnosis and a tailored management plan. It respects the patient's autonomy by actively involving them in the assessment process and validating their subjective experience while also seeking objective correlates. An incorrect approach that relies solely on a single assessment tool or method fails to capture the multifaceted nature of chronic pain. For instance, relying exclusively on a numerical rating scale without exploring functional impact or psychosocial factors neglects crucial dimensions of the pain experience. This can lead to misdiagnosis, ineffective treatment, and patient dissatisfaction, potentially breaching the duty of care owed to the patient. Another incorrect approach might involve prematurely attributing the pain to a specific cause without adequate investigation, which could lead to inappropriate interventions and a failure to address the true underlying issues. Such an approach could be seen as negligent and not in line with the standards expected of a pain specialist. Furthermore, dismissing or downplaying the patient's subjective report without a valid clinical reason would be ethically unsound and could erode the therapeutic alliance. The professional decision-making process for similar situations should involve a systematic approach. 1. Patient-centered history taking. Elicit a detailed account of the pain, its onset, characteristics, aggravating and relieving factors, and its impact on daily life. 2. Comprehensive physical examination. Assess for neurological deficits, musculoskeletal abnormalities, and other physical signs relevant to the reported pain. 3. Consideration of psychosocial factors. Explore the patient's mood, coping mechanisms, social support, and any psychological distress that may be influencing their pain experience. 4. Utilization of validated assessment tools. Employ a range of tools, including pain intensity scales, functional questionnaires, and mood assessments, to gather objective data that complements subjective reports. 5. Differential diagnosis. Formulate a list of potential diagnoses and plan further investigations if necessary. 6. Collaborative goal setting. Work with the patient to establish realistic treatment goals that address both pain reduction and functional improvement. This structured approach ensures that all relevant information is gathered, leading to a holistic understanding of the patient's pain and facilitating the development of an effective and ethical management plan. Question 2. The performance metrics show a statistically significant increase in reported adverse events and a decrease in patient-reported outcome measures following a specific cohort of central nervous system interventions over the past 6 months. What is the most appropriate immediate next step for the pain medicine unit to address this trend? Option A. Implement a temporary moratorium on the specific central nervous system interventions until further investigation can be completed without immediate consultation with affected patients or staff. Option B. Conduct individual performance reviews for all practitioners involved in the central nervous system interventions, focusing on technique and adherence to standard operating procedures without broader systemic analysis. Option C. Convene a multidisciplinary team meeting to review the performance data, identify potential contributing factors through a root cause analysis, and consult relevant FFP-Manska guidelines for CNS interventions to inform a targeted improvement strategy. Option D. Update the unit's standard operating procedures for central nervous system interventions with a generic statement emphasizing caution, and rely on individual practitioner discretion for future practice. The correct answer is C. Convene a multidisciplinary team meeting to review the performance data, identify potential contributing factors through a root cause analysis, and consult relevant FFP-Manska guidelines for CNS interventions to inform a targeted improvement strategy. Explanation: this scenario presents a common implementation challenge in pain medicine, translating evidence-based guidelines for central nervous system (CNS) interventions into consistent, high-quality clinical practice. The challenge lies in ensuring that the performance metrics, which reflect actual patient outcomes and procedural adherence, are accurately interpreted and acted upon. This requires a nuanced understanding of both the technical aspects of CNS interventions and the broader professional responsibilities governed by the Faculty of Pain Medicine, Australian and New Zealand College of Anaesthetists, FFP-Manska, standards. The correct approach involves a systematic, evidence-based review of the performance data, focusing on identifying specific areas for improvement in the CNS intervention pathway. This aligns with the FFP-Manska commitment to continuous quality improvement and patient safety. By engaging relevant stakeholders, including proceduralists, anesthetists, and allied health professionals, and by referencing established guidelines for CNS procedures, the team can develop targeted strategies. This collaborative and data-driven method ensures that interventions are not only technically sound, but also ethically delivered, meeting the standards of care expected within the Australian and New Zealand context. An incorrect approach would be to dismiss the performance metrics as mere statistical noise or to implement superficial changes without a thorough root cause analysis. For instance, attributing the dip in performance solely to individual practitioner variability without investigating systemic factors like equipment availability, training gaps, or patient selection criteria would be a failure to adhere to best practice. Another failure would be to implement a blanket policy change that disproportionately impacts patient access or safety without adequate consultation or evidence. Such actions could contravene FFP-Manska guidelines on professional conduct, patient care standards, and the ethical imperative to provide evidence-based medicine. Professionals should approach such situations by first acknowledging the data and its potential implications. A structured problem-solving framework, such as a Plan-Do-Study-Act cycle, is invaluable. This involves defining the problem, performance metrics, developing potential solutions based on evidence and stakeholder input, implementing these solutions, studying their impact, and then acting on the findings. Crucially, this process must be transparent, documented, and aligned with the regulatory and ethical framework of the FFP-Manska. Question 3. The monitoring system demonstrates a patient experiencing significant breakthrough pain episodes despite a stable dose of long-acting opioid analgesia. The patient reports a burning, shooting quality to this pain, which is not adequately relieved by their current medication. Considering the potential for central sensitization and the role of neurotransmitters in modulating pain signaling, which of the following adjunctive therapeutic strategies would be most appropriate to investigate for this patient? Option A. Introduction of a medication known to modulate noradrenergic and serotonergic descending inhibitory pathways. Option B. A significant increase in the dose of the current long-acting opioid. Option C. Referral for a psychological assessment to explore the patient's coping mechanisms. Option D. A trial of a benzodiazepine to address potential anxiety associated with the pain. Correct answer is A. Introduction of a medication known to modulate noradrenergic and serotonergic descending inhibitory pathways. Explanation. The monitoring system demonstrates a patient experiencing breakthrough pain despite being on a stable opioid regimen. This scenario is professionally challenging because it requires the clinician to move beyond simple dose titration and consider the complex neurobiological underpinnings of persistent pain, specifically the role of neurotransmitters. The FFP Manska curriculum emphasizes a comprehensive understanding of pain mechanisms, including neurochemical pathways, to guide effective management. The correct approach involves a nuanced assessment of neurotransmitter systems that may be dysregulated in chronic pain states, such as the descending facilitatory and inhibitory pathways involving noradrenaline and serotonin, or the role of glutamate and substance P in central sensitization. Understanding these mechanisms allows for the targeted addition of adjuvant analgesics that modulate these neurotransmitter systems, thereby addressing the underlying pathophysiology rather than just the symptom of pain. This aligns with best professional practice as outlined by the faculty, which promotes evidence-based, multimodal pain management strategies that address the complexity of chronic pain. It reflects a commitment to patient-centered care by seeking to improve pain control through a deeper understanding of the biological drivers of the patient's suffering. An incorrect approach would be to solely increase the opioid dose. While opioids are a cornerstone of pain management, their efficacy can be limited in certain chronic pain states due to mechanisms like opioid-induced hyperalgesia or the involvement of non-opioid pathways. Relying solely on dose escalation without considering neurotransmitter modulation may lead to increased side effects, tolerance, and a failure to achieve adequate pain relief, potentially breaching the duty of care to provide optimal management. Another incorrect approach would be to dismiss the breakthrough pain as psychological without a thorough neurobiological and physical assessment. While psychological factors are important in pain perception, attributing persistent, objectively monitored breakthrough pain solely to psychological causes without investigating underlying neurochemical changes is a failure to adhere to a comprehensive pain management framework. This could lead to delayed or inappropriate treatment, potentially causing patient harm and contravening ethical obligations to investigate all plausible causes of pain. A further incorrect approach would be to initiate a new, unproven adjuvant therapy without considering the patient's specific neurotransmitter profile or the evidence base for its use in their particular pain condition. This could lead to adverse drug interactions, patient harm, and a failure to provide evidence-based care, which is a core tenet of professional practice in pain medicine. The professional reasoning process should involve a systematic evaluation of the patient's pain presentation, including the nature of the breakthrough pain, its timing, and any associated symptoms. This should be followed by a review of the current treatment regimen and consideration of the known neurobiological mechanisms contributing to the patient's specific pain syndrome. Based on this assessment, a multimodal treatment plan can be developed, which may include pharmacological interventions targeting specific neurotransmitter systems, alongside non-pharmacological approaches. Continuous reassessment and adjustment of the treatment plan are crucial to ensure optimal outcomes and patient safety. Question 4. Regulatory review indicates that a 55-year-old patient presents with a 5-year history of widespread musculoskeletal pain, described as a constant dull ache with intermittent sharp shooting exacerbations. They report significant fatigue, sleep disturbance, and a pervasive sense of anxiety and low mood, which they attribute to their chronic pain. Previous treatments, including NSAID and paracetamol, have provided minimal relief. On examination, there are no specific neurological deficits, and musculoskeletal examination reveals generalized tenderness but no overt inflammatory signs. Considering the principles of pain physiology relevant to chronic pain syndromes, which of the following diagnostic and management approaches is most appropriate? Option A. Advise the patient that their symptoms are likely psychosomatic and recommend counseling without further medical investigation. Option B. Conduct a detailed assessment of pain characteristics, functional impact, and psychological state, and consider a trial of a medication targeting central neurotransmitter pathways, alongside referral for physiotherapy and psychological therapy. Option C. Focus on identifying a single peripheral nociceptive source through further imaging and laboratory investigations, and manage this source aggressively. Option D. Prescribe a short course of stronger opioid analgesics to manage the acute exacerbations, and provide immediate symptom relief. Correct answer is B. Conduct a detailed assessment of pain characteristics, functional impact, and psychological state, and consider a trial of a medication targeting central neurotransmitter pathways, alongside referral for physiotherapy and psychological therapy. Explanation. This scenario presents a professionally challenging situation due to the complexity of chronic pain etiology and the need for a comprehensive, multidisciplinary approach, which is a cornerstone of best practice in pain medicine, as espoused by the FFP-Manska curriculum. The patient's presentation with widespread somatic and neuropathic pain, coupled with significant psychological distress and functional impairment, necessitates a thorough understanding of pain physiology beyond simple nociception. The challenge lies in differentiating between peripheral and central sensitization mechanisms, understanding the role of the limbic system and prefrontal cortex in pain perception and modulation, and recognizing how psychological factors can amplify or perpetuate pain signals. The correct approach represents best professional practice because it aligns with the FFP-Manska emphasis on evidence-based, patient-centered care that addresses the biopsychosocial model of pain. A detailed history and examination, including specific questioning about pain characteristics, impact on function, and psychological state, is crucial for accurate diagnosis and management planning. This approach allows for the identification of potential central sensitization phenomena, which are often implicated in chronic widespread pain conditions. Furthermore, it facilitates the development of a tailored management plan that may include pharmacological interventions targeting specific neurotransmitter pathways, alongside non-pharmacological therapies such as physiotherapy, psychological support, and interventional procedures, all of which are integral to comprehensive pain management. An incorrect approach that focuses solely on pharmacological management without a thorough assessment of the underlying physiological mechanisms and psychosocial factors would be professionally unacceptable. This would represent a failure to adhere to the biopsychosocial model, potentially leading to suboptimal outcomes and continued patient suffering. Such an approach might overlook the contribution of central sensitization, where the nervous system becomes hypersensitive, leading to amplified pain signals. This could result in inappropriate prescribing of analgesics that do not address the core physiological dysregulation. Another incorrect approach would be to dismiss the patient's psychological distress as a secondary issue or a consequence of pain, rather than recognizing its potential role in modulating pain perception and chronicity. This failure to integrate psychological assessment and management into the pain management plan would be a significant ethical and professional failing, as it ignores the well-established interplay between psychological state and pain processing. A third incorrect approach might involve prematurely resorting to invasive procedures without a clear understanding of the specific physiological targets and potential benefits, especially in the absence of a comprehensive diagnostic workup. This could lead to unnecessary risks and complications for the patient. The professional decision-making process for similar situations should involve a systematic approach. 1. Comprehensive assessment. Gather detailed history, perform thorough physical and neurological examinations, and consider relevant investigations to elucidate the pain etiology. 2. Physiological understanding. Apply knowledge of pain physiology, including nociception, peripheral and central sensitization, and the role of descending inhibitory and facilitatory pathways. 3. Biopsychosocial integration. Actively assess and integrate psychological and social factors into the diagnostic and management framework. 4. Evidence-based management. Develop a multimodal treatment plan based on current evidence, tailored to the individual patient's needs and physiological profile. 5. Ongoing evaluation. Regularly review treatment efficacy, patient progress, and adjust the management plan as required. Question 5. The audit findings indicate a potential underutilization of pharmacological agents known to modulate descending inhibitory pain pathways in patients with chronic non-malignant pain. Which of the following represents the most appropriate next step in addressing this finding, consistent with best practice in pain medicine within the Australian regulatory framework? Option A. Increase opioid dosages for all patients with chronic pain who are not responding adequately to current analgesia, irrespective of the specific class of medication. Option B. Dismiss the audit findings as a minor discrepancy, as the primary focus should remain on managing acute pain exacerbations. Option C. Initiate a targeted review of patient records to identify specific patient cohorts who might benefit from the introduction or optimization of medications that enhance descending inhibition, such as certain antidepressants or anticonvulsants, and develop a protocol for their appropriate use. Option D. Immediately cease all non-opioid analgesics for patients identified in the audit, as they may be contributing to aberrant pain signaling. The correct answer is C. Initiate a targeted review of patient records to identify specific patient cohorts who might benefit from the introduction or optimization of medications that enhance descending inhibition, such as certain antidepressants or anticonvulsants, and develop a protocol for their appropriate use. Explanation: this scenario presents a professional challenge due to the need to reconcile audit findings with established clinical practice guidelines for managing chronic pain, specifically concerning the descending pain pathways. The audit highlights a potential deviation from best practice, requiring a nuanced understanding of neurophysiological principles and their application in pain management within the Australian regulatory framework for medical practitioners. The correct approach represents best professional practice because it involves a systematic, evidence-based review of patient management strategies. This aligns with the principles of continuous quality improvement mandated by the Australian Health Practitioner Regulation Agency, (AHPRA), and the college's own standards for pain medicine practice. Specifically, it addresses the potential underutilization of pharmacological agents that modulate descending inhibitory pathways, such as certain antidepressants, e.g., SNRI, TCA, or anticonvulsants, e.g., gabapentinoids, which are recognized for their efficacy in neuropathic and chronic pain conditions. This approach prioritizes patient safety and optimal outcomes by ensuring that treatment plans are informed by current understanding of pain neurobiology and are tailored to individual patient needs, as expected under the Medical Board of Australia's Good Medical Practice Code of Conduct. An incorrect approach involving the immediate cessation of all non-opioid analgesics without a comprehensive reassessment would be professionally unacceptable. This fails to acknowledge the potential benefits of these medications in modulating descending pain pathways and could lead to increased pain, functional decline, and patient distress, potentially breaching the duty of care. Furthermore, it bypasses the established process of medication review and adjustment, which is a cornerstone of chronic pain management and a requirement for maintaining professional standards. Another incorrect approach, focusing solely on increasing opioid dosages without considering adjunctive therapies that target descending pathways, is also professionally deficient. While opioids are part of pain management, an over-reliance without exploring multimodal strategies, including those impacting descending inhibition, can lead to increased risks of opioid-related harms, tolerance, and hyperalgesia. This approach neglects the comprehensive understanding of pain mechanisms and fails to adhere to guidelines promoting judicious opioid prescribing and the use of non-pharmacological and adjuvant pharmacological interventions. A further incorrect approach of dismissing the audit findings as irrelevant to the management of descending pain pathways demonstrates a failure to engage with quality improvement processes and a lack of understanding of the complex interplay between different pain modulatory systems. This stance is contrary to the ethical obligation to maintain professional competence and to contribute to the improvement of healthcare services. The professional decision-making process for similar situations should involve 1. Acknowledging and critically evaluating audit findings. 2. Reviewing current evidence-based guidelines and literature pertaining to the specific clinical area, in this case, descending pain pathways and their modulation. 3. Conducting a thorough reassessment of patient cohorts or individual cases identified in the audit. 4. Developing and implementing a revised management strategy that incorporates best practices with a focus on patient safety and efficacy. 5. Monitoring the outcomes of the revised strategy and engaging in ongoing quality improvement cycles. This process is guided by AHPRA regulations, the college's standards, and the overarching ethical principles of medical practice in Australia. Question 6. Quality control measures reveal that a patient presenting with chronic severe lower back pain radiating down the leg has had 2 separate lumbar spine MRI scans performed over a 6-month period. Both reports from the same radiology group indicate no significant degenerative changes, disc herniation, or spinal stenosis. However, the patient's pain persists and significantly impacts their daily function, with no clear correlation to the reported imaging findings. What is the most appropriate next step in managing this patient's diagnostic uncertainty? Option A. Arrange for a multidisciplinary pain assessment, including a review of the existing imaging by a pain specialist with expertise in musculoskeletal imaging, alongside a comprehensive clinical reevaluation and consideration of functional imaging modalities if indicated. Option B. Reassure the patient that the imaging is definitive and suggest they focus on non-pharmacological pain relief methods without further diagnostic investigation. Option C. Order a third, more detailed lumbar spine MRI with a different radiology group, focusing on advanced sequences without further clinical correlation. Option D. Advise the patient that imaging is normal and the pain is likely functional, recommending referral to a psychologist for pain management strategies. The correct answer is A. Arrange for a multidisciplinary pain assessment, including a review of the existing imaging by a pain specialist with expertise in musculoskeletal imaging, alongside a comprehensive clinical reevaluation and consideration of functional imaging modalities if indicated. Explanation. Scenario analysis. This scenario presents a professional challenge stemming from a discrepancy between a radiologist's interpretation of diagnostic imaging and the clinical presentation of a patient with chronic pain. The core difficulty lies in reconciling objective imaging findings with subjective patient experience and the potential for subtle or atypical pathology that may not be immediately apparent on standard imaging protocols. This requires a nuanced understanding of pain etiology, the limitations of diagnostic imaging, and the importance of a holistic patient assessment. The FFP-Manska framework emphasizes evidence-based practice and patient-centered care, necessitating a thorough investigation when clinical and radiological findings diverge. Correct approach analysis. The correct approach involves a multifaceted strategy that prioritizes patient well-being and diagnostic accuracy. This includes a detailed review of the imaging by a senior pain specialist or radiologist with expertise in musculoskeletal or neurological imaging, considering the specific pain complaint. Crucially, it necessitates a comprehensive reevaluation of the patient's clinical history, physical examination, and any previous investigations. This iterative process allows for the identification of potential alternative diagnoses. The need for further targeted imaging, e.g., functional imaging, advanced MRI sequences, or referral to other specialists. This aligns with the FFP-Manska commitment to continuous professional development and the application of best available evidence in pain management, ensuring that diagnostic pathways are not prematurely closed based on initial, potentially incomplete information. Incorrect approaches analysis. Dismissing the patient's symptoms solely based on a normal initial imaging report is a significant ethical and professional failing. It contravenes the principle of patient-centered care and can lead to delayed diagnosis and inadequate treatment, potentially exacerbating the patient's suffering. This approach neglects the possibility of imaging limitations, such as the inability of standard protocols to detect certain pathologies or the presence of functional pain disorders. Accepting the radiologist's report without further clinical correlation and assuming the pain is purely psychosomatic without a thorough differential diagnosis is also professionally unacceptable. While psychological factors can influence pain perception, they should not be assumed as the sole cause without excluding organic pathology. This approach risks misdiagnosis and can damage the patient-physician relationship. Ordering further, nonspecific imaging without a clear hypothesis derived from the clinical presentation and initial imaging review is inefficient and potentially exposes the patient to unnecessary radiation or cost. While further imaging may be indicated, it should be targeted and justified by a specific clinical question. Professional reasoning. Professionals facing such a dilemma should adopt a systematic approach. Firstly, acknowledge the discrepancy and the need for further investigation. Secondly, engage in a thorough clinical reassessment, integrating the patient's narrative with objective findings. Thirdly, consult with relevant imaging specialists, providing them with detailed clinical information to guide their review. Fourthly, consider the limitations of the initial imaging and explore the possibility of alternative or complementary diagnostic modalities. Finally, maintain open communication with the patient, explaining the diagnostic process and involving them in decision-making. This approach embodies the principles of thoroughness, collaboration, and patient advocacy central to advanced pain medicine practice. Question 7. Implementation of a comprehensive physical examination for a patient presenting with chronic low back pain, reporting severe functional limitations and significant pain intensity, but demonstrating minimal objective findings on initial neurological and musculoskeletal screening. Which of the following approaches best reflects best professional practice within the FFP-Manska framework? Option A. Conduct a detailed neurological examination, including assessment of motor strength, sensation, reflexes, and coordination, alongside a thorough musculoskeletal evaluation of the lumbar spine and surrounding structures, while also exploring potential psychosocial contributors to pain perception and functional impairment. Option B. Conclude that the patient's pain is likely psychosomatic due to the lack of objective physical findings and focus solely on psychological interventions. Option C. Immediately refer the patient for advanced imaging such as MRI without a comprehensive physical examination, assuming a significant underlying structural pathology. Option D. Perform a brief, superficial physical examination of the lumbar spine, accepting the patient's subjective report as the primary diagnostic indicator without further objective investigation. The correct answer is A. Conduct a detailed neurological examination, including assessment of motor strength, sensation, reflexes, and coordination, alongside a thorough musculoskeletal evaluation of the lumbar spine and surrounding structures, while also exploring potential psychosocial contributors to pain perception and functional impairment. Explanation. Scenario analysis. This scenario presents a common challenge in pain medicine where a patient's subjective report of pain and functional limitation appears discordant with objective physical examination findings. This discrepancy requires a clinician to navigate potential underlying pathologies, psychological factors, and the patient's perception of their condition, all within the framework of evidence-based practice and professional conduct. The challenge lies in avoiding premature judgment, ensuring a comprehensive assessment, and maintaining a patient-centered approach while adhering to the standards of care expected by the Faculty of Pain Medicine, Australian and New Zealand College of Anaesthetists, FFP-Manska. Correct approach analysis. The correct approach involves a systematic and thorough physical examination, focusing on identifying objective signs that correlate with or explain the patient's reported symptoms. This includes a detailed neurological assessment, musculoskeletal evaluation, and assessment for referred pain patterns. The clinician must also consider the impact of psychological factors on pain perception and function, as outlined in guidelines for chronic pain management, which emphasize a biopsychosocial model. This approach aligns with the FFP-Manska emphasis on comprehensive patient assessment and the application of evidence-based diagnostic strategies. It respects the patient's experience while diligently seeking to understand the underlying mechanisms of their pain, thereby informing appropriate management strategies. Incorrect approaches analysis. One incorrect approach involves dismissing the patient's reported pain due to a lack of objective findings on a cursory examination. This fails to acknowledge the complexity of pain, particularly chronic pain, where objective signs may be subtle or absent and can lead to patient distress and a breakdown in the therapeutic relationship. Ethically, it breaches the principle of beneficence and non-maleficence by potentially withholding appropriate investigation and treatment. Another incorrect approach is to immediately attribute the discrepancy solely to psychological factors without a thorough physical examination. While psychological factors are important, this premature conclusion can be perceived as dismissive and stigmatizing, potentially overlooking treatable organic causes. It deviates from a systematic diagnostic process and may violate professional standards that mandate a comprehensive physical assessment. A third incorrect approach is to focus exclusively on a single anatomical region based on the patient's initial complaint, neglecting a broader systemic assessment. Pain can be complex and multifactorial, and a narrow focus may miss crucial diagnostic clues or coexisting conditions. This lack of thoroughness can lead to misdiagnosis and suboptimal patient outcomes, contravening the FFP-Manska expectation of comprehensive clinical evaluation. Professional reasoning. Professionals should approach such discrepancies with a commitment to a thorough, systematic, and patient-centered assessment. This involves active listening, a comprehensive physical examination tailored to the presenting complaint and potential differential diagnosis, and consideration of the biopsychosocial context of pain. Decision-making should be guided by a process of differential diagnosis, seeking objective evidence to support or refute hypotheses, and engaging the patient collaboratively in the diagnostic and management process. Adherence to FFP-Manska guidelines and ethical principles ensures that patient care is both effective and compassionate. Question 8. Benchmark analysis indicates that a patient presents with chronic widespread pain, fatigue, and significant functional impairment. Despite extensive investigations, no clear organic pathology has been identified. The patient reports a history of significant life stressors and expresses feelings of hopelessness. Which of the following approaches best reflects a comprehensive risk assessment for this patient within the FFP-Manska framework? Option A. Prescribing a high dose of opioid analgesics to manage the severe pain, with the expectation that this will improve their mood and function. Option B. Conducting a detailed physical examination and ordering further advanced imaging studies to definitively exclude any subtle organic pathology before considering other factors. Option C. Acknowledging the patient's distress and initiating a referral to a psychologist for assessment and management of potential mood disorders contributing to their pain experience, while continuing to monitor for any emerging organic signs. Option D. Reassuring the patient that all organic causes have been ruled out and advising them to focus on positive thinking to overcome their pain. The correct answer is C. Acknowledging the patient's distress and initiating a referral to a psychologist for assessment and management of potential mood disorders contributing to their pain experience, while continuing to monitor for any emerging organic signs. Explanation. Scenario analysis. This scenario presents a professionally challenging situation due to the inherent complexity of diagnosing and managing psychogenic pain within the Australian healthcare system, specifically under the purview of the FFP-Manska. Differentiating between organic and psychogenic pain requires a nuanced understanding of patient presentation, a comprehensive biopsychosocial assessment, and the ability to navigate potential diagnostic uncertainty and patient expectations. The challenge lies in avoiding premature closure, ensuring patient safety, and adhering to ethical principles of beneficence and non-maleficence, all while operating within the established professional standards and guidelines of the faculty. Correct approach analysis. The correct approach involves a systematic and comprehensive biopsychosocial assessment. This aligns with the FFP-Manska emphasis on holistic patient care and the understanding that pain is a complex phenomenon influenced by biological, psychological, and social factors. A thorough history, including detailed exploration of psychological stressors, coping mechanisms, and past psychiatric history, alongside a meticulous physical examination and appropriate investigations to rule out organic pathology, is paramount. This approach respects the patient's experience, avoids stigmatization, and facilitates the development of an integrated management plan that addresses all contributing factors. It is consistent with the principles of evidence-based practice and the ethical imperative to provide patient-centered care, as expected within the Australian medical regulatory framework. Incorrect approaches analysis. Focusing solely on physical examination and investigation without a thorough psychological and social assessment is an incomplete approach. This risks overlooking crucial contributing factors to the patient's pain experience, potentially leading to misdiagnosis, ineffective treatment, and patient frustration. It fails to acknowledge the biopsychosocial model of pain, which is fundamental to contemporary pain management practice and implicitly supported by FFP-Manska guidelines. Dismissing the patient's pain as all in their head without a comprehensive assessment is ethically unacceptable and professionally damaging. This approach is dismissive, stigmatizing, and violates the principle of respecting patient autonomy and their subjective experience of pain. It demonstrates a lack of empathy and a failure to engage in a therapeutic alliance, potentially leading to a breakdown in the doctor-patient relationship and a refusal of care. Such an approach would be contrary to the ethical codes governing medical practitioners in Australia. Initiating aggressive pharmacological treatment for presumed organic pain without adequately exploring psychogenic contributors can lead to polypharmacy, adverse drug events, and a failure to address the root causes of the pain. This is a reactive rather than a proactive approach and does not reflect best practice in pain management, particularly when psychogenic factors are suspected. It prioritizes symptom suppression over a comprehensive understanding and management of the pain syndrome. Professional reasoning. professionals should approach suspected psychogenic pain with a framework that prioritizes a comprehensive biopsychosocial assessment. This involves 1. Active listening and empathy, creating a safe space for the patient to describe their pain experience without judgment. 2. Thorough history taking, exploring the onset, duration, character, aggravating and relieving factors of pain, alongside detailed inquiry into psychological state, social circumstances, and functional impact. 3. Physical examination and investigations, conducting a systematic physical examination and ordering appropriate investigations to exclude or confirm organic pathology, guided by clinical suspicion. 4. Differential diagnosis, considering a broad range of potential diagnoses, including both organic and psychogenic contributors. 5. Collaborative management planning, developing a treatment plan in partnership with the patient, which may involve a multidisciplinary approach including psychological therapies, physiotherapy, and judicious pharmacological management. 6. Ongoing reassessment, regularly reviewing the patient's progress and adjusting the management plan as needed. This systematic approach ensures that all aspects of the patient's pain are considered, leading to more effective and ethical care, in line with the standards expected by the FFP-MANSCA. Question 9. Stakeholder feedback indicates a registrar is struggling to manage a patient with chronic widespread pain who reports severe discomfort, yet exhibits minimal objective findings on physical examination and standard investigations. The registrar is unsure how to proceed, questioning whether the pain is real or if they are missing a crucial diagnostic element. Which of the following approaches best reflects a comprehensive understanding of pain mechanisms and best practice in pain medicine within the Australian and New Zealand context? Option A. Reassure the patient that there are no objective findings and suggest that the pain is likely psychosomatic, recommending referral to a psychologist for management of anxiety. Option B. Advise the patient that without clear objective evidence of tissue damage, further investigation and treatment are unlikely to be beneficial. Option C. Conduct a thorough biopsychosocial assessment, exploring potential central sensitization, neuropathic components, and the impact of psychological and social factors on pain perception and function, while considering further targeted investigations if indicated. Option D. Increase the dose of opioid analgesics significantly, as the patient reports severe pain, and monitor for side effects. The correct answer is C. Conduct a thorough biopsychosocial assessment, exploring potential central sensitization, neuropathic components, and the impact of psychological and social factors on pain perception and function, while considering further targeted investigations if indicated. Explanation. Scenario analysis. This scenario presents a common challenge in pain medicine where a patient's subjective experience of pain, while valid, may not align with objective findings or established pathophysiological models. The professional challenge lies in validating the patient's distress and suffering, while also adhering to evidence-based practice and the ethical obligation to provide appropriate care. It requires a nuanced understanding of pain mechanisms beyond simple nociception, acknowledging the complex interplay of biological, psychological, and social factors. The registrar's dilemma is to reconcile the patient's report with their clinical assessment and the limitations of current diagnostic tools, necessitating a thoughtful approach to differential diagnosis and management. Correct approach analysis. The correct approach involves a comprehensive assessment that moves beyond a purely biomedical model to incorporate biopsychosocial factors. This aligns with the principles of contemporary pain management, which recognize that pain is a multidimensional experience. By considering psychological distress, social context, and potential central sensitization mechanisms, the registrar is employing a holistic approach consistent with best practice guidelines for chronic pain management. This approach respects the patient's experience while systematically exploring potential underlying mechanisms and contributing factors, allowing for a more targeted and effective management plan. This is supported by the Faculty of Pain Medicine's emphasis on understanding the broad spectrum of pain conditions and their management. Incorrect approach is analysis. One incorrect approach is to dismiss the patient's reported pain severity solely based on the absence of clear structural or inflammatory findings. This fails to acknowledge the reality of neuropathic pain, central sensitization, or the impact of psychological factors on pain perception, which are all well-established pain mechanisms. Ethically, this approach risks invalidating the patient's suffering and can lead to a breakdown in the therapeutic relationship, potentially violating the principle of beneficence. It also contravenes the FFP-Manska expectation of a thorough and empathetic assessment. Another incorrect approach is to immediately escalate opioid therapy without a comprehensive reassessment of pain mechanisms and contributing factors. While opioids may have a role in certain pain conditions, their indiscriminate use in the absence of a clear indication or understanding of the underlying pain generator can lead to opioid-induced hyperalgesia, addiction, and other adverse effects. This approach neglects the ethical imperative to do no harm and fails to explore safer, more effective, and evidence-based non-pharmacological or multimodal strategies, which are central to responsible pain management as advocated by the faculty. A third incorrect approach is to attribute the pain solely to psychological factors without adequately exploring and ruling out other potential organic causes. While psychological distress can significantly amplify pain, it is crucial to conduct a thorough differential diagnosis. Misattributing pain solely to psychological factors can lead to delayed diagnosis of treatable organic conditions and can also be perceived by the patient as dismissive, undermining trust and adherence to treatment. This approach fails to uphold the principle of justice by not providing equitable investigation and care. Professional reasoning. Professionals should adopt a systematic, patient-centered approach. This involves active listening to the patient's narrative, conducting a thorough history and physical examination, and considering a broad differential diagnosis that encompasses nociceptive, neuropathic, and nociplastic pain mechanisms. The biopsychosocial model should guide the assessment, prompting consideration of psychological state, social support, and functional impact. When faced with discrepancies between subjective reports and objective findings, it is essential to explore potential explanations such as central sensitization, complex regional pain syndromes, or the influence of psychological factors, rather than dismissing the patient's experience. Management should be evidence-based, multimodal, and tailored to the individual patient's specific pain mechanisms and circumstances, with ongoing reassessment and shared decision-making. Question 10. Cost-benefit analysis shows that a novel laboratory test for a specific inflammatory marker shows promise in identifying a subset of patients with chronic neuropathic pain who may respond better to a particular class of medications. However, the test is currently expensive, and its long-term impact on patient outcomes and healthcare resource utilization is not yet fully established in the Australian context. What is the most appropriate approach for a pain medicine specialist to consider regarding the implementation of this test? Option A. Immediately incorporate the test into routine clinical practice for all patients presenting with chronic neuropathic pain to ensure no patient misses out on potential benefits. Option B. Advise patients that the test is too expensive and not yet proven, and therefore should not be considered for use in their management. Option C. Rely on the manufacturer's promotional material and the experiences of overseas colleagues to justify its immediate widespread adoption. Option D. Initiate a pilot study within the specialist's practice or a collaborating institution to gather local data on the test's utility, cost-effectiveness, and impact on patient management, while continuing to use established diagnostic criteria for patient selection. The correct answer is D. Initiate a pilot study within the specialist's practice or a collaborating institution to gather local data on the test's utility, cost-effectiveness, and impact on patient management, while continuing to use established diagnostic criteria for patient selection. Explanation. This scenario presents a common implementation challenge in pain medicine, balancing the potential benefits of novel diagnostic laboratory tests with their practical and ethical considerations within the Australian regulatory framework for medical practitioners. The challenge lies in discerning when the evidence supporting a new test justifies its routine adoption, considering resource allocation, patient safety, and the established standards of care. The correct approach represents best professional practice because it prioritizes evidence-based medicine and a structured, ethical implementation process. It aligns with the principles of good medical practice as outlined by the Medical Board of Australia, which requires practitioners to maintain professional standards, act in the best interests of patients, and use resources wisely. Specifically, it acknowledges the need for robust clinical validation and consideration of cost-effectiveness before widespread adoption, ensuring that patient care is not compromised by unproven or excessively expensive interventions. This approach also reflects the FFP-Manska commitment to advancing pain medicine through rigorous scientific evaluation. An incorrect approach that involves immediate widespread adoption of a new laboratory test without sufficient evidence of its clinical utility or cost-effectiveness is professionally unacceptable. This could lead to unnecessary patient exposure to potentially unvalidated diagnostic pathways, increased healthcare costs without demonstrable patient benefit, and a deviation from evidence-based practice. Such an approach may contravene the Medical Board of Australia's guidelines on professional conduct and the responsible use of diagnostic technologies. Another incorrect approach, which is to dismiss the test entirely due to initial cost concerns, without a thorough evaluation of its potential benefits and long-term cost savings, is also professionally flawed. It can stifle innovation and prevent patients from accessing potentially superior diagnostic tools that could ultimately improve outcomes and reduce overall healthcare expenditure. It fails to engage in a balanced assessment of value. Finally, an approach that relies solely on anecdotal evidence or the enthusiasm of a few practitioners, without a systematic review of scientific literature or consideration of broader clinical impact, is professionally unsound. This can lead to the adoption of practices that are not supported by robust evidence, potentially harming patients and misallocating healthcare resources. The professional reasoning process for such situations should involve a systematic evaluation of new diagnostic technologies. This includes critically appraising the scientific literature for evidence of accuracy, reliability, clinical utility, and safety. It also necessitates considering the test's impact on patient management, treatment outcomes, and cost-effectiveness within the Australian healthcare system. Collaboration with colleagues, engagement with professional bodies like the ANZCA Faculty of Pain Medicine, and adherence to guidelines from regulatory authorities are crucial steps in making informed decisions that benefit patients and the healthcare system. Question 11. Investigation of a novel serum biomarker for chronic neuropathic pain, showing promising preliminary results in small international studies, requires a structured approach for potential integration into Australian clinical practice. Which of the following represents the most appropriate initial step for a pain medicine specialist in Australia? Option A. Relying on anecdotal evidence from colleagues who have used the biomarker in their practice to gauge its effectiveness before considering any formal evaluation. Option B. Reviewing the biomarker's registration status with the Therapeutic Goods Administration, TGA, and searching for peer-reviewed publications demonstrating its diagnostic accuracy, clinical utility, and safety profile in relevant patient populations. Option C. Immediately incorporating the biomarker into routine patient assessments, assuming its potential benefits outweigh any risks based on the preliminary international findings. Option D. Recommending the biomarker for further research funding, without assessing its current TGA status or existing clinical evidence, deferring any clinical consideration. The correct answer is B. Reviewing the biomarker's registration status with the Therapeutic Goods Administration, TGA, and searching for peer-reviewed publications demonstrating its diagnostic accuracy, clinical utility, and safety profile in relevant patient populations. Explanation. This scenario presents a professional challenge due to the evolving nature of pain biomarkers and the need for clinicians to integrate novel, yet potentially unvalidated, diagnostic tools into their practice within the Australian healthcare system, specifically under the purview of the Faculty of Pain Medicine, ANZCA. The core difficulty lies in balancing the potential benefits of early and accurate diagnosis with the ethical and regulatory obligations to provide evidence-based, safe, and effective patient care. Clinicians must navigate the landscape of emerging research, regulatory approvals, and the practicalities of implementation in a clinical setting, all while adhering to the standards set by the ANZCA. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based evaluation of novel biomarkers. This aligns with the principles of good medical practice and the ethical duty of care, which mandate that interventions offered to patients should be supported by robust scientific evidence and demonstrated clinical utility. In Australia, this involves considering the TGA registration status, the availability of peer-reviewed literature supporting diagnostic accuracy and clinical impact, and the potential for integration into existing diagnostic pathways. Adopting a biomarker without this rigorous vetting process risks patient harm, misdiagnosis, and inappropriate treatment, which would contravene professional standards and potentially lead to medico-legal issues. An incorrect approach that involves immediate adoption of a biomarker based solely on preliminary research findings, without further validation or regulatory approval, represents a significant ethical and regulatory failure. This bypasses the established pathways for ensuring patient safety and efficacy, potentially exposing patients to unnecessary investigations or treatments based on unproven diagnostic information. Such an approach could be seen as a breach of the duty of care and a failure to adhere to the principles of evidence-based medicine, which are foundational to professional conduct in Australia. Another incorrect approach, such as dismissing a promising biomarker due to a lack of immediate widespread clinical adoption, could also be professionally suboptimal. While caution is warranted, an overly conservative stance might delay the introduction of beneficial diagnostic tools, thereby failing to optimize patient care. The professional reasoning process should involve a critical appraisal of the available evidence, consideration of the biomarker's potential impact on patient outcomes and resource utilization, and consultation with peers and relevant professional bodies. This iterative process ensures that decisions are informed, ethical, and aligned with the best interests of patients and the advancement of pain medicine within the Australian context. Question 12. What factors determine the comprehensiveness and validity of a functional assessment in Australian pain medicine practice, as guided by the FFP-Manska framework? Option A. The sole reliance on objective physical examination findings to quantify functional limitations. Option B. The integration of subjective patient reports, objective physical examination findings, validated outcome measures, and consideration of psychosocial factors. Option C. The primary focus on pain intensity scores as the sole determinant of functional impairment. Option D. The exclusive use of generic, non-validated self-report questionnaires without clinical correlation. The correct answer is B. The integration of subjective patient reports, objective physical examination findings, validated outcome measures, and consideration of psychosocial factors. Explanation. Scenario analysis. This scenario is professionally challenging because functional assessment in pain medicine requires a nuanced understanding of a patient's subjective experience and its objective impact on their life. It moves beyond purely biomedical models to encompass biopsychosocial factors, which are crucial for effective pain management and rehabilitation. The challenge lies in integrating diverse information sources, managing patient expectations, and ensuring that the assessment is comprehensive, valid, and ethically sound within the Australian regulatory landscape for pain medicine specialists. The FFP-Manska framework emphasizes a holistic approach, requiring clinicians to consider not just pain intensity, but also its effect on daily activities, work, social engagement, and psychological well-being. Correct approach analysis. The correct approach involves a multimodal functional assessment that integrates subjective patient reports with objective measures and observations. This aligns with the principles of evidence-based practice and the biopsychosocial model of pain, which is implicitly supported by the FFP-Manska curriculum and the broader Australian healthcare system's emphasis on patient-centered care. Specifically, this approach would involve 1. Comprehensive history taking, eliciting detailed information about the nature of the pain, its impact on daily living, e.g., sleep, mobility, self-care, social activities, work capacity, and psychological state, e.g., mood, anxiety, coping mechanisms. 2. Standardized questionnaires and outcome measures, utilizing validated tools, e.g., Oswestry Disability Index Brief Pain Inventory, SF36, to quantify functional limitations and pain impact, providing a benchmark for progress. 3. Physical examination, assessing physical function, range of motion, strength, and identifying any contributing musculoskeletal or neurological factors. 4. Observation of functional tasks, where appropriate, observing the patient perform specific activities relevant to their reported limitations. 5. Consideration of psychosocial factors, actively exploring the patient's beliefs about pain, their social support system, and any barriers to recovery. This comprehensive approach ensures that the assessment is thorough, objective where possible, and directly informs the development of a tailored, multidisciplinary management plan that addresses the patient's specific needs and goals, in line with the standards expected of a fellow of the Faculty of Pain Medicine. Incorrect approaches analysis, focusing solely on pain intensity scores without considering functional impact, represents a significant regulatory and ethical failure. This biomedical-centric approach neglects the core tenet of functional assessment, which is to understand how pain affects a patient's life. It fails to meet the expectations of comprehensive pain management and can lead to inappropriate treatment plans that do not address the patient's real-world limitations. Ethically, it is a failure of beneficence and non-maleficence, as it may lead to ineffective or even harmful interventions by not fully understanding the problem. Relying exclusively on objective physical examination findings without incorporating subjective patient reports is also professionally unacceptable. While objective findings are important, pain is a subjective experience. Ignoring the patient's lived experience and their self-reported functional limitations leads to an incomplete and potentially misleading assessment. This approach risks misinterpreting the severity of the patient's condition and can result in a management plan that is disconnected from their actual needs and goals, potentially causing distress and frustration. Using only generic, non-validated self-report questionnaires without clinical correlation or specific functional observation is another failure. While validated questionnaires are valuable, they are tools to aid clinical judgment, not replace it. Without clinical correlation, these scores may not accurately reflect the patient's functional capacity or the underlying pathology. This can lead to over- or underestimation of disability, impacting treatment decisions and potentially leading to suboptimal outcomes. Professional reasoning. Professionals should employ a structured, patient-centered decision-making framework for functional assessment. This begins with understanding the referral reason and the patient's primary concerns. The framework should then guide the selection of appropriate assessment tools and methods, ensuring a balance between subjective reporting, objective measurement, and clinical observation. Crucially, the framework must incorporate a continuous feedback loop with the patient, ensuring their goals and perspectives are central to the assessment process. Regular review and adaptation of the assessment strategy based on emerging information are also vital. This systematic approach, grounded in the biopsychosocial model and adhering to Australian professional standards, ensures that functional assessments are robust, ethical, and maximally beneficial to the patient. Question 13. When evaluating a 65-year-old patient with chronic neuropathic pain, a history of moderate renal impairment, eGFR 45 ml/min/1, 73 m2, and concurrent use of a benzodiazepine for anxiety, which of the following approaches to initiating an adjuvant medication is most appropriate and aligned with Australian regulatory frameworks and FFP-MANSCA guidelines? Option A. Introduce pregabalin at a standard starting dose without dose adjustment, as it is a first-line agent for neuropathic pain. Option B. Prescribe a high dose of amitriptyline immediately to achieve rapid pain relief, given its established efficacy in neuropathic pain. Option C. Initiate a low dose of gabapentin, titrating slowly upwards while monitoring renal function and for signs of sedation, with a clear plan for regular review of efficacy and adverse effects. Option D. Recommend a short course of a strong opioid analgesic, as it is the most potent option for severe neuropathic pain. Correct answer is C. Initiate a low dose of gabapentin, titrating slowly upwards while monitoring renal function and for signs of sedation, with a clear plan for regular review of efficacy and adverse effects. Explanation. Scenario analysis. This scenario presents a common clinical challenge in pain medicine, managing neuropathic pain in a patient with multiple comorbidities and potential drug interactions. The professional challenge lies in balancing the need for effective pain relief with the imperative to minimize risks associated with polypharmacy and specific patient vulnerabilities. The patient's history of renal impairment and concurrent use of other central nervous system depressants necessitates a cautious and evidence-based approach to introducing new medications, particularly adjuvants with known side effect profiles. Correct approach analysis. The correct approach involves a systematic and evidence-based selection of an adjuvant medication, prioritizing agents with a favorable risk-benefit profile in the context of the patient's specific comorbidities. This includes considering the pharmacokinetic and pharmacodynamic properties of potential agents, their established efficacy in neuropathic pain, and their known interactions with the patient's existing medications and renal function. A thorough assessment of the patient's current pain severity, functional impact, and previous treatment responses is crucial. Initiating a low dose of a well-tolerated agent with a clear titration plan and regular monitoring for efficacy and adverse effects while also considering non-pharmacological adjuncts, represents best professional practice. This aligns with the principles of good medical practice and the FFP Manska curriculum, which emphasizes patient-centered care, evidence-based medicine, and comprehensive management of chronic pain. Incorrect approaches analysis, an approach that prioritizes a medication solely based on its perceived potency without adequately considering the patient's renal impairment and potential for drug interactions, is professionally unacceptable. For example, selecting a medication with significant renal excretion without dose adjustment or contraindication in moderate renal impairment would violate principles of safe prescribing and patient safety, potentially leading to toxicity. Similarly, choosing an adjuvant with a high risk of additive central nervous system depression without careful consideration of the patient's existing sedating medications could lead to dangerous sedation, respiratory depression, and falls, contravening the duty of care. Another unacceptable approach would be to disregard the patient's previous treatment failures and represcribe a medication that has already proven ineffective or poorly tolerated, demonstrating a lack of thorough patient assessment and adherence to best practice guidelines. Failing to document the rationale for medication selection, the discussion of risks and benefits with the patient, and the monitoring plan would also represent a failure in professional record-keeping and communication. Professional reasoning. Professionals should employ a structured decision-making process that begins with a comprehensive assessment of the patient's pain, functional status, and medical history, including comorbidities and current medications. This should be followed by a review of current evidence-based guidelines for the management of neuropathic pain, considering the specific patient profile. The selection of an adjuvant medication should be a deliberate choice based on efficacy, safety, tolerability, and cost-effectiveness, with a clear understanding of potential drug interactions and contraindications. A shared decision-making process with the patient, involving a discussion of treatment options, potential benefits, risks, and alternatives, is paramount. A robust monitoring plan, including regular review of efficacy, adverse effects, and functional outcomes, should be established and documented. This systematic approach ensures patient safety, optimizes treatment outcomes, and upholds professional and ethical standards. Question 14. Risk assessment procedures indicate a patient with chronic neuropathic pain, a history of opioid misuse, and comorbid hypertension and anxiety is experiencing a significant increase in pain intensity, impacting their daily function. The patient reports current opioid therapy is providing only partial relief and expresses concern about potential side effects. Which of the following represents the most appropriate initial management strategy in accordance with FFP Manska guidelines? Option A. Immediately discontinue all opioid analgesia and initiate a rapid detoxification protocol. Option B. Conduct a comprehensive reassessment of pain, functional status, and psychosocial factors, and explore optimization of non-opioid analgesics and adjuvant therapies, alongside non-pharmacological interventions, while setting clear functional goals. Option C. Increase the dose of the current opioid medication to achieve better pain relief, given the patient's reported partial response. Option D. Refer the patient for a psychiatric evaluation to address the anxiety component, assuming the pain is primarily psychosomatic. The correct answer is B. Conduct a comprehensive reassessment of pain, functional status, and psychosocial factors, and explore optimization of non-opioid analgesics and adjuvant therapies, alongside non-pharmacological interventions, while setting clear functional goals. Explanation. This scenario presents a common clinical challenge in pain medicine, managing chronic neuropathic pain in a patient with multiple comorbidities and a history of opioid misuse. The professional challenge lies in balancing effective pain relief with the significant risks associated with pharmacological interventions, particularly opioids, while adhering to the strict guidelines and ethical obligations set forth by the Faculty of Pain Medicine, Australian and New Zealand College of Anaesthetists, FFP Manska. Careful judgment is required to select an evidence-based, patient-centered approach that minimizes harm and optimizes function. The correct approach represents best professional practice because it prioritizes a multimodal, non-opioid-centric strategy, aligning with current FFP Manska guidelines and the principles of responsible prescribing. This involves a comprehensive assessment of the patient's pain, functional status, psychological factors, and risk profile, Initiating or titrating non-opioid analgesics, including adjuvant medications like gabapentinoids or certain antidepressants, is a cornerstone of managing neuropathic pain. Furthermore, incorporating non-pharmacological therapies such as physiotherapy, psychological support, and interventional procedures, where appropriate, forms a holistic treatment plan. Regular reassessment, clear goal setting, and open communication with the patient are crucial for safe and effective management. This approach adheres to the FFP-Manska emphasis on evidence-based practice, patient safety, and the judicious use of all therapeutic modalities, particularly in the context of potential opioid dependence or misuse. An incorrect approach that solely focuses on escalating opioid doses without a comprehensive reassessment and consideration of non-opioid alternatives represents a significant regulatory and ethical failure. This would contravene FFP-Manska guidelines that advocate for a cautious approach to opioid prescribing, especially in patients with a history of misuse or significant comorbidities. Such an approach risks exacerbating the patient's underlying issues, increasing the likelihood of adverse events, and potentially leading to opioid-induced hyperalgesia or dependence. It fails to address the multifactorial nature of chronic pain and neglects the importance of non-pharmacological interventions. Another incorrect approach might involve abruptly discontinuing all pain medication without adequate support or alternative strategies. This would be ethically unsound, potentially causing significant patient distress, uncontrolled pain, and a breakdown in the therapeutic relationship. It fails to meet the professional obligation to provide ongoing care and manage withdrawal symptoms or rebound pain effectively. A third incorrect approach could be to dismiss the patient's pain as purely psychological without a thorough pharmacological and physical assessment. While psychological factors are integral to chronic pain, neglecting the biological and physical components of neuropathic pain would be a failure to provide comprehensive care and could lead to misdiagnosis and inappropriate treatment, violating professional standards of care. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's pain etiology, severity, and impact on function. This should be followed by a risk-benefit analysis of all available pharmacological and non-pharmacological treatment options, guided by current evidence and FFP-Manska guidelines. A collaborative approach with the patient, involving shared decision-making and clear goal setting, is paramount. Regular monitoring for efficacy, adverse effects, and adherence is essential, with a willingness to adjust the treatment plan based on the patient's response and evolving clinical picture. Question 15. The efficiency study reveals that a significant proportion of patients presenting with chronic non-malignant pain are being managed with a limited range of non-opioid analgesic classes. Considering the fellowship of the Faculty of Pain Medicine, Australian and New Zealand College of Anaesthetists, FFP-Manska, curriculum, and Australian regulatory frameworks, which of the following approaches best reflects optimal clinical practice in selecting non-opioid analgesics for these patients? Option A. Limiting the choice of non-opioid analgesics to those with the lowest acquisition cost, even if alternative agents might offer superior efficacy or a better safety profile for specific patient subgroups. Option B. Prioritizing the use of a single, widely prescribed non-opioid analgesic class that has demonstrated general efficacy in pain management, irrespective of individual patient characteristics or specific pain etiology. Option C. Conducting a comprehensive patient assessment to determine the specific pain mechanisms, comorbidities, potential contraindications, and previous treatment responses, then selecting non-opioid analgesics from a range of evidence-based classes that best match the individual patient's profile and adhere to TGA guidelines. Option D. Relying primarily on patient self-report of pain relief with a particular non-opioid analgesic, without further clinical assessment or consideration of objective measures or potential adverse effects. Correct answer is B. Prioritizing the use of a single, widely prescribed non-opioid analgesic class that has demonstrated general efficacy in pain management, irrespective of individual patient characteristics or specific pain etiology. Explanation. This scenario presents a professional challenge due to the need to balance evidence-based practice with patient-specific factors and the evolving regulatory landscape concerning non-opioid analgesics within the Australian context. The FFP-Manska Fellowship requires a deep understanding of pharmacotherapy, including the appropriate selection and application of non-opioid analgesics. Adhering to guidelines set by bodies such as the Therapeutic Goods Administration, TGA, and professional colleges. Careful judgment is required to ensure patient safety, efficacy, and cost-effectiveness, all while navigating potential limitations in evidence for specific patient populations or complex pain presentations. The correct approach represents best professional practice because it prioritizes a comprehensive assessment of the patient's pain profile, comorbidities, and previous treatment responses. This aligns with the Australian Medical Board's Good Medical Practice Code of Conduct, which mandates that doctors provide high-quality care, practice ethically, and maintain professional standards. Specifically, it reflects the principle of patient-centered care, ensuring that treatment decisions are individualized and evidence-informed. The selection of non-opioid analgesics should be guided by current Australian guidelines and the latest available evidence, considering factors like renal and hepatic function, potential drug interactions, and the patient's risk profile for adverse events, as often detailed in TGA-approved product information and professional consensus statements. An incorrect approach that relies solely on a single class of non-opioid analgesic without considering patient factors or alternative options fails to meet the standard of care. This could lead to suboptimal pain management, increased risk of adverse events, and potential contravention of professional obligations to provide appropriate and evidence-based treatment. For instance, prescribing a non-steroidal anti-inflammatory drug, NSAID, to a patient with a history of peptic ulcer disease or significant renal impairment without adequate consideration of contraindications or alternative agents would represent a significant ethical and regulatory failure, potentially breaching the duty of care and contravening TGA recommendations for NSAID use. Similarly, overlooking the potential for paracetamol toxicity in patients with liver disease or failing to consider the specific indications and contraindications for anticonvulsants or antidepressants in neuropathic pain demonstrates a lack of due diligence and adherence to best practice principles. The professional decision-making process for similar situations should involve a systematic approach. 1. Thorough patient assessment. Understanding the pain etiology, intensity, duration, impact on function, and psychosocial factors. 2. Review of medical history. Identifying comorbidities, allergies, and previous treatment responses and adverse events. 3. Consideration of evidence-based guidelines. Consulting current Australian guidelines for pain management and specific drug classes. 4. Individualized treatment selection. Choosing non-opioid analgesics based on the patient's specific profile, weighing benefits against risks. 5. Monitoring and review. Regularly assessing treatment efficacy, safety, and patient adherence, with a willingness to adjust the treatment plan as needed. 6. Patient education. Ensuring the patient understands their medication, its purpose, potential side effects, and when to seek medical advice. Question 16. Operational review demonstrates a pattern where patients undergoing lumbar epidural steroid injections for chronic radicular pain occasionally report new or worsening neurological deficits post-procedure, including sensory changes and motor weakness, which in some instances have persisted beyond the expected duration of transient effects. This review prompts a reevaluation of the informed consent process and post-procedure management protocols for this common intervention. Which of the following represents the most appropriate approach to mitigate the risk and manage potential complications related to nerve injury during lumbar epidural steroid injections, in accordance with FFP-MANSCA guidelines and Australian medical practice? Option A. Emphasize the general risks of bleeding and infection in the informed consent process, as these are the most common complications, and rely on standard post-operative instructions for any emergent neurological concerns. Option B. Advise patients that transient neurological symptoms are common after epidural injections and usually resolve spontaneously, encouraging them to wait several weeks before reporting any persistent deficits to avoid unnecessary investigations. Option C. Ensure the informed consent process explicitly details the potential for nerve injury, including sensory and motor deficits, their potential permanence, and the importance of immediate reporting of any new neurological symptoms post-procedure, coupled with a clear protocol for prompt neurological assessment and management if such symptoms arise. Option D. Focus the informed consent discussion primarily on the efficacy of the procedure and the expected duration of pain relief, with a brief mention of potential discomfort at the injection site as the main procedural risk. Correct answer is A. Emphasize the general risks of bleeding and infection in the informed consent process, as these are the most common complications, and rely on standard post-operative instructions for any emergent neurological concerns. Explanation. This scenario presents a professionally challenging situation due to the potential for significant patient harm arising from a known, albeit uncommon, complication of a commonly performed interventional pain procedure. The challenge lies in balancing the therapeutic benefits of the procedure against the inherent risks, and in ensuring that the patient's informed consent adequately reflects these risks. The requirement for prompt and appropriate management of the complication further adds to the complexity, demanding rapid clinical assessment and decisive action within the established medical, legal, and ethical framework. The correct approach represents best professional practice by prioritizing patient safety and adhering to the principles of good medical practice as outlined by the Faculty of Pain Medicine, Australian and New Zealand College of Anaesthetists, FFP Manska. This includes thorough pre-procedure assessment, comprehensive informed consent that specifically addresses the risk of nerve injury and its potential sequelae, meticulous procedural technique to minimize risk, and a robust post-procedure monitoring and management plan for identified complications. Prompt recognition and management of the complication, including appropriate investigation and referral, aligns with the duty of care owed to the patient and the standards expected of a pain medicine specialist. An incorrect approach that fails to adequately inform the patient about the specific risk of nerve injury and its potential long-term consequences before the procedure would represent a failure in the process of obtaining valid informed consent. This contravenes the ethical and legal requirements for patient autonomy and the right to make informed decisions about their health care. Failing to recognize or appropriately manage the developing neurological deficit post-procedure would constitute a breach of the duty of care, potentially leading to suboptimal patient outcomes and professional misconduct. Similarly, dismissing the patient's reported symptoms without a thorough clinical evaluation and investigation would be a significant failure in professional responsibility and patient management. The professional decision-making process for similar situations should involve a systematic approach. 1. Risk assessment. Identify all potential complications associated with the planned procedure, considering their likelihood and severity. 2. Informed consent. Ensure the patient fully understands the nature of the procedure, its benefits, risks, including specific, albeit rare, complications like nerve injury, and alternatives. This requires clear, understandable communication and an opportunity for the patient to ask questions. 3. Procedural diligence. Employ best practice techniques to minimize the risk of complications during the procedure. 4. Post-procedure vigilance. Implement a clear plan for post-procedure monitoring, including patient education on warning signs and symptoms, and a defined pathway for follow-up and review. 5. Complication management. If a complication is suspected or identified, act promptly to confirm the diagnosis, initiate appropriate management, and involve other specialists if necessary. 6. Documentation. Maintain thorough and accurate records of all discussions, procedures, and management decisions. Question 17. System analysis indicates a patient presence for a pain consultation requesting a specific, potentially invasive, and not universally recommended interventional procedure for their chronic back pain, stating they have researched it extensively and believe it is the only solution. The patient appears distressed and insistent. As a pain medicine specialist, adhering to FFP Manska guidelines and Australian medical practice, what is the most appropriate initial approach to this patient's pain history taking? Option A. Conduct a thorough and empathetic pain history, exploring the patient's pain experience, understanding of the requested procedure, their expectations, and any psychosocial factors before discussing treatment options. Option B. Immediately agree to the requested procedure to respect the patient's autonomy and their perceived understanding of their condition. Option C. Politely but firmly refuse the requested procedure, explaining that it is not indicated for their condition based on current evidence. Option D. Focus solely on the physical examination and diagnostic imaging to confirm the anatomical source of pain before addressing the patient's request. Correct answer is A. Conduct a thorough and empathetic pain history, exploring the patient's pain experience, understanding of the requested procedure, their expectations, and any psychosocial factors before discussing treatment options. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's expressed desire for a specific treatment and the clinician's professional judgment regarding its appropriateness and potential risks. The clinician must navigate the ethical principles of patient autonomy, beneficence, and non-maleficence, all within the framework of the Fellowship of the Faculty of Pain Medicine, Australian and New Zealand College of Anaesthetists, FFP Manska, guidelines and relevant Australian medical practice legislation. The core difficulty lies in respecting the patient's right to make informed decisions about their care, while ensuring that those decisions are based on accurate information and do not lead to harm. The correct approach represents best professional practice because it prioritizes a comprehensive and empathetic pain history, seeking to understand the underlying biopsychosocial factors contributing to the patient's pain and their request. This aligns with the FFP Manska curriculum's emphasis on a holistic approach to pain management, which extends beyond purely pharmacological interventions. By thoroughly exploring the patient's pain experience, their understanding of the proposed treatment, and their expectations, the clinician can identify potential misunderstandings, contraindications, or alternative, more appropriate management strategies. This approach upholds the principle of informed consent, ensuring the patient can make a truly autonomous decision based on a clear understanding of risks, benefits, and alternatives. It also demonstrates beneficence by actively seeking the best outcome for the patient and non-maleficence, by avoiding potentially harmful or ineffective treatments. An incorrect approach that involves immediately acceding to the patient's request without further investigation fails to uphold the clinician's duty of care. This could be considered a breach of professional standards and potentially negligent, as it bypasses the essential process of clinical assessment and risk stratification. It disregards the clinician's responsibility to provide evidence-based care and to protect the patient from harm, thereby violating the principles of beneficence and non-maleficence. Furthermore, it undermines the informed consent process by not ensuring the patient fully comprehends the implications of their request. Another incorrect approach, that of dismissing the patient's request outright without adequate exploration, disrespects patient autonomy. While the clinician may have concerns, a blunt refusal without understanding the patient's perspective can lead to patient dissatisfaction, erosion of trust, and a reluctance to engage in future treatment. This approach fails to acknowledge the patient's lived experience of pain and their agency in their own healthcare journey, potentially leading to a breakdown in the therapeutic relationship. It also misses opportunities to educate the patient and explore their underlying concerns, which might be addressed through other means. The professional decision-making process for similar situations should involve a structured, patient-centered approach. This begins with active listening and empathetic engagement to build rapport and understand the patient's narrative. A thorough pain history, encompassing the characteristics of the pain, its impact on function and quality of life, previous treatments, and psychosocial factors, is paramount. This should be followed by a comprehensive physical examination and review of relevant investigations. Crucially, the clinician must then engage in a shared decision-making process, discussing the findings, potential treatment options, including the patient's requested treatment, if appropriate, and alternatives, their respective risks and benefits, and the evidence supporting them. This ensures that the patient's values and preferences are integrated into the treatment plan, while the clinician maintains their professional responsibility for providing safe and effective care. Question 18. The assessment process reveals a patient with refractory neuropathic pain, unresponsive to multiple pharmacological and conservative therapies. The patient expresses interest in a novel neuromodulation technique involving direct spinal cord stimulation, which has limited published data in peer-reviewed Australian journals, but shows promising preliminary results in international case series. The physician is considering proceeding with this intervention. What is the most appropriate next step in managing this complex CNS pain presentation, adhering strictly to FFP Manska principles? Option A. Refer the patient to a colleague who has extensive experience with this specific neuromodulation technique, without independently verifying the evidence base or conducting a detailed patient assessment. Option B. Undertake a comprehensive review of the international literature for robust evidence supporting the efficacy and safety of the proposed neuromodulation technique. Conduct a thorough neurological examination and discuss the risks, benefits, and alternatives with the patient, ensuring fully informed consent before considering the intervention within the scope of established guidelines. Option C. Proceed with the neuromodulation intervention immediately, given the patient's refractory pain and the promising international case series, to offer a potential solution. Option D. Focus solely on optimizing pharmacological management, as novel CNS interventions carry inherent risks and are not yet widely established within the Australian context. The correct answer is B. Undertake a comprehensive review of the international literature for robust evidence supporting the efficacy and safety of the proposed neuromodulation technique. Conduct a thorough neurological examination and discuss the risks, benefits, and alternatives with the patient, ensuring fully informed consent before considering the intervention within the scope of established guidelines. Explanation. This scenario presents a professional challenge due to the inherent complexity of managing central nervous system (CNS) pain, particularly when considering novel or less established therapeutic modalities. The physician must balance the imperative to provide effective pain relief with the ethical and regulatory obligations to ensure patient safety, informed consent, and adherence to established clinical guidelines and evidence-based practice. The rapid evolution of interventional pain management techniques, especially those involving direct CNS access or modulation, necessitates a rigorous approach to assessment and decision-making. The correct approach represents best professional practice because it prioritizes a comprehensive, evidence-based, and patient-centered evaluation. This involves a thorough understanding of the patient's pain etiology, a detailed neurological assessment, and a critical appraisal of the available scientific literature supporting the proposed intervention. Adherence to the Fellowship of the Faculty of Pain Medicine, Australian and New Zealand College of Anaesthetists, FFP-MANSCA guidelines, which emphasize a structured approach to patient assessment, treatment planning, and risk-benefit analysis, is paramount. Obtaining fully informed consent, ensuring the intervention is within the scope of practice, and having appropriate patient selection criteria are all integral to this best practice. This approach aligns with the ethical principles of beneficence, non-maleficence, and patient autonomy, as well as the regulatory requirements for safe and effective medical practice in Australia and New Zealand. An incorrect approach involving immediate adoption of a novel, unproven CNS intervention without adequate evidence or patient-specific justification would represent a significant regulatory and ethical failure. This could contravene FFP-MANSCA guidelines on evidence-based practice and patient safety. Proceeding without a thorough neurological assessment or failing to adequately explore less invasive, established treatment options would violate the principle of non-maleficence and potentially lead to iatrogenic harm. Furthermore, bypassing a detailed discussion of risks, benefits, and alternatives, thereby compromising informed consent, would be a direct breach of ethical and legal obligations. Relying solely on anecdotal evidence or the enthusiasm of a particular practitioner without independent critical evaluation also falls short of professional standards and could expose both the patient and the practitioner to undue risk. Professional decision-making in such complex CNS pain management cases should follow a structured framework. This begins with a comprehensive diagnostic workup to accurately identify the pain generator. Subsequently, all available evidence-based treatment options, ranging from conservative management to advanced interventional techniques, should be considered and discussed with the patient. A thorough risk-benefit analysis, tailored to the individual patient's comorbidities and preferences, is essential. The decision to proceed with any intervention, particularly novel ones, must be supported by robust scientific evidence and align with established clinical guidelines. Ongoing monitoring and evaluation of treatment efficacy and safety are also critical components of this process. Question 19. The audit findings indicate a potential discrepancy in the interpretation of neuroanatomical structures implicated in a patient's chronic neuropathic pain. Which of the following approaches best reflects a rigorous risk assessment of the neuroanatomical basis of this pain, according to the principles guiding pain medicine practice in Australia and New Zealand? Option A. Dismissing the neuroimaging findings as potentially artifactual, given the complexity of interpreting central nervous system structures in chronic pain. Option B. Prioritizing the prescription of broad-spectrum analgesics based on the patient's subjective pain score, without detailed neuroanatomical consideration. Option C. Systematically correlating the patient's reported pain characteristics and neuroimaging findings with the known neuroanatomy of nociception, pain modulation, and sensory processing, including central pathways. Option D. focusing solely on the peripheral nerve distribution of the patient's symptoms, assuming central contributions are less significant in this presentation. The correct answer is C. Systematically correlating the patient's reported pain characteristics and neuroimaging findings with the known neuroanatomy of nociception, pain modulation, and sensory processing, including central pathways. Explanation: scenario analysis. This scenario presents a professional challenge due to the potential for misinterpreting neuroanatomical findings in the context of chronic pain management. Clinicians' understanding of the complex pathways involved in pain processing is crucial for accurate diagnosis and effective treatment planning. Failure to correctly identify the relevant neuroanatomical structures and their roles can lead to inappropriate interventions, patient harm, and a breach of professional standards expected by the FFP-MANSCA. The audit findings highlight a need for rigorous application of neuroanatomical knowledge to clinical practice. Correct approach analysis. The correct approach involves a systematic review of the patient's neuroimaging and clinical presentation, correlating findings with established knowledge of pain pathways. This aligns with the FFP-MANSCA emphasis on evidence-based practice and the application of scientific principles to pain medicine. Specifically, understanding the somatosensory cortex, thalamus, brainstem nuclei, and spinal cord pathways is fundamental. Correct approach would involve identifying which of these structures, if implicated by the audit findings, are most likely contributing to the patient's specific pain presentation, thereby guiding further investigation or management. This demonstrates a commitment to diagnostic accuracy and patient safety, which are paramount in pain medicine and are implicitly or explicitly covered by the college's educational and assessment frameworks. Incorrect approach is analysis. An approach that focuses solely on the superficial sensory nerves without considering central processing mechanisms is incorrect. This fails to acknowledge the complex neuroanatomy of pain, which extends beyond peripheral pathways to include central sensitization and modulation. Such an approach risks overlooking significant contributions from the central nervous system to the patient's pain experience, leading to incomplete or ineffective management. This would be a failure to apply the depth of knowledge expected of a pain medicine specialist. An approach that prioritizes pharmacological interventions based on broad symptom categories without a clear neuroanatomical rationale is also incorrect. Pharmacotherapy is a cornerstone of pain management. Its selection should be informed by an understanding of the underlying neurobiological mechanisms. Without this, treatment may be suboptimal, potentially leading to adverse effects or lack of efficacy, and does not reflect the rigorous diagnostic process expected. An approach that dismisses the neuroimaging findings as irrelevant without a thorough neuroanatomical correlation is professionally unacceptable. The audit findings are presented as a basis for review, and ignoring them constitutes a failure to engage with potentially critical diagnostic information. This demonstrates a lack of due diligence and a disregard for the systematic evaluation required in pain medicine. Professional reasoning. Professionals should approach such situations by first understanding the specific neuroanatomical structures and pathways involved in the patient's reported pain. This involves recalling and applying knowledge of the spinothalamic tract, trigeminothalamic tract, somatosensory cortex, limbic system involvement, and descending modulatory pathways. The next step is to critically evaluate the audit findings in light of this neuroanatomical framework. This involves asking, what specific neuroanatomical abnormalities are suggested by the audit findings, and how do these relate to the patient's pain phenotype? The decision-making process should then involve formulating differential diagnoses based on these correlations and planning investigations or interventions that are specifically targeted at the identified neuroanatomical correlates of pain. This systematic, evidence-based approach ensures that management is precise, effective, and prioritizes patient safety, aligning with the high standards of the FFP-MANSCA. Question 20. The monitoring system demonstrates a patient on a neuromodulatory agent for chronic neuropathic pain exhibiting increased sensory amplification and hyperalgesia, despite a reported subjective decrease in baseline pain intensity. Option A. Discontinue the neuromodulatory agent abruptly and reassess pain management strategies. Option B. Initiate a comprehensive review of the patient's neurochemical profile and medication adherence, considering the potential for paradoxical neurotransmitter effects or downstream receptor desensitization. Option C. Immediately increase the dosage of the neuromodulatory agent to overcome the perceived resistance to treatment. Option D. attribute the increased sensory amplification and hyperalgesia primarily to psychological distress and refer for counseling. The correct answer is B. Initiate a comprehensive review of the patient's neurochemical profile and medication adherence, considering the potential for paradoxical neurotransmitter effects or downstream receptor desensitization. Explanation: this scenario presents a professional challenge due to the subtle yet significant implications of neurotransmitter modulation in chronic pain management, particularly when patient response deviates from expected patterns. The FFP MANSCO requires practitioners to possess a deep understanding of neuropharmacology to ensure safe and effective patient care, adhering to the Australian regulatory framework for medical practice. Careful judgment is required to differentiate between expected physiological responses, adverse effects, and potential underlying pathological changes that might necessitate a change in management strategy. The correct approach represents best professional practice because it prioritizes a comprehensive, evidence-based assessment of the patient's clinical presentation in the context of their prescribed neuromodulatory therapy. This aligns with the principles of good medical practice as outlined by the Medical Board of Australia, which mandates that practitioners maintain appropriate knowledge and skills and provide care that is within their scope of practice. Specifically, understanding the role of neurotransmitters like GABA, glutamate, and noradrenaline in pain pathways allows for informed interpretation of treatment effects and adverse events. A systematic review of the patient's response, considering the known mechanisms of action of their medications and potential interactions, is crucial for optimizing pain relief and minimizing harm. This approach is ethically sound, promoting patient well-being and autonomy through informed and effective treatment. An incorrect approach that focuses solely on increasing the dose without reassessing the underlying neurotransmitter dynamics would be professionally unacceptable. This fails to acknowledge that altered neurotransmitter function can manifest in various ways, and simply escalating a medication might exacerbate an imbalance or mask a different underlying issue, potentially leading to adverse effects or treatment failure. This could contravene the Medical Board of Australia's guidelines on professional conduct and the safe prescribing of medications. Another incorrect approach, such as discontinuing the medication abruptly without a clear clinical rationale or alternative plan, could lead to withdrawal symptoms or a rebound in pain, causing significant patient distress and potentially worsening their condition. This demonstrates a lack of understanding of the pharmacokinetics and pharmacodynamics of the prescribed agents, and a failure to manage the patient holistically. A third incorrect approach, attributing the symptoms solely to psychological factors without a thorough neurobiological assessment, overlooks the complex interplay between biological, psychological, and social factors in chronic pain. While psychological well-being is important, a purely psychological explanation without considering the neurochemical underpinnings of pain can lead to inadequate or inappropriate treatment, potentially violating the duty of care owed to the patient. The professional reasoning process for similar situations should involve a structured approach. First, a thorough clinical assessment of the patient's current symptoms and response to treatment. Second, a review of the patient's medication regimen, considering the known roles of neurotransmitters in their pain condition and the potential mechanisms of action and side effects of the prescribed drugs. Third, consideration of differential diagnoses, including potential drug interactions, tolerance, or progression of the underlying pain pathology. And finally, development of a revised management plan based on this comprehensive assessment, always prioritizing patient safety and optimal outcomes within the Australian regulatory framework.